All right. So just want to say welcome to everybody. We have some people still trickling in, but we have our first collaboration webinar between the ambulatory care and the endocrine metabolism PRNs. Today we have some speakers who will be going over their experiences in troubleshooting some common CGM problems, which many of us I'm sure encounter in our practices managing diabetes. We have three wonderful speakers today. We have Ashley Higbee, who is a clinical pharmacy specialist at the UT Southwestern Family Medicine Clinic in Dallas, Texas, where she practices in team-based care and chronic disease state management, including diabetes. She is also an associate professor at Texas Tech University Health Science Center, Jerry H. Hodge School of Pharmacy, and she currently serves as the 2022 to 2023 chair for the ACCP Education and Training PRN. We also have Caitlin O'Brien, who is a clinical pharmacy specialist at the Boston Medical Center, working in an adult internal medicine clinic, providing chronic disease state management, diabetes care, and education. She also serves as the residency program director for the ambulatory care PGY2 residency. And last but not least, we have Diana Isaacs, who is an endocrine clinical pharmacy specialist and CGM program coordinator at the Cleveland Clinic. She serves on the American Diabetes Association Professional Practice Committee, the committee that updates the ADA standards of care. And she also was the ADCES Diabetes Care and Education Specialist in 2020. We ask that any audience members who have any questions to save it at the very end, where we will have an open session. But if you have any questions throughout the presentation, you can feel free to enter them in the chat where we'll be taking note of them. With that, I'd like to pass it on to Ashley Higbee.
Hello and welcome. So I'm going to kick us off this afternoon or this morning, depending on where you're located. I just want to let you guys know, Caitlin and I don't have any disclosures, and Diane Isaac's disclosures are listed there. Our learning objectives, so by the end of the presentation today, you should be able to describe barriers to optimal use of CGMs, describe or discuss real-world strategies to overcome these barriers, and outline how the Identify, Configure, and Collaborate framework, or ICC framework, can be used to address many of these common barriers. So what is the ICC framework? It's a framework used to essentially overcome barriers to technology use and therapeutic inertia. So I'll be starting us off with the Identify section, going over the right technology, right person, right time. But first, we want to hear about what are your barriers and challenges. All right, so it looks like we're kind of all over the board with various different challenges, with the most being insurance and cost, and we will be going over some of those tips and advice to help overcome that barrier. All right, so where to start? First, begin by outlining benefits to people with diabetes, so your patients, your providers, or your colleagues in your practice. Just a quick overview of CGMs for those that might be more in the initial stages of CGMs and trying to get them implemented in practice. CGMs are small medical devices used to measure blood glucose continuously over the course of a person's day, and more importantly, throughout the night, especially for those with hypoglycemia. So it's just a tiny sensor under the skin that measures the interstitial glucose level, and that's the glucose found in the fluid between the cells. So what CGMs, multiple studies have shown that CGMs have been found to decrease glycemic variability, time in hypoglycemia, hypoglycemic events, and decrease A1C, while increasing the time in range. So the blood sugars of where we want those targets. So why CGM? So A1Cs are just really not alone enough. We also have blood sugars, but that's just point in time, and where sugars might have been and where they are currently. But time and range can really help us determine where this glycemic variability is. I just had a patient the other day who was CGM, and her A1C looked great, but she kept complaining of lows. So we were able to, with the CGM, figure out where her lows were happening, to be able to really get her more in a therapeutic state. And so CGMs really help us connect the dots and also see the trends of the dots. So just not where blood glucose has been and where it is, but where it's also going. So these might be some of the barriers you might be experiencing as well: lack of time, resources, training, education, patients' ability and willingness to follow protocols or understanding this, hypoglycemic concerns. And really, this is just can be really overwhelming, particularly in the inflammation stage. What I recommend is the Association of Diabetes Care and Education Specialists, ADCES, the American Pharmacists Association. They put out this great resource that I want you to be familiar with, and that is the Personal CGM Implementation Playbook. They also have one for professional CGMs, but really, in following these steps, hopefully these steps will help with overcoming some of that overwhelmingness and save you time in the long run as well. So let's start with identifying the demand for a personal CGM. So thinking about your patients that might be a good candidate for CGMs, those that have multiple daily injections of insulin or insulin pump, maybe they have checking their sugars with lots of finger sticks. Maybe their finger sticks don't quite match their A1C, lack of hypoglycemia awareness or asymptomatic hypoglycemia, nocturnal hypoglycemia, maybe even some suspected DOM phenomenon with these rising morning sugars, suspected postprandial hyperglycemia, or just non-adherence in checking it, to really kind of help us be able to manage appropriately and help decrease that glycemic variability. So these would all be particularly good candidates that you may have already identified for your patients. So next would be to really think about establishing the team and define roles. So your teams may be made up of different people within your clinic. I consider reaching out. So just by being here, you're already kind of reaching out to us by helping get more information about this. But again, pharmacists all over the country have been doing CGM programs and services. So reach out to others who may have already implemented. They can save you a lot of time, figure out what worked, what didn't. Meet with your healthcare team and leadership, identify key stakeholders, get input, address concerns. This was really key when we were starting in my practice, getting this started, was finding a physician who was very passionate about diabetes and glucose management and willing to really meet with me with leadership and to get this rolling. So really, I encourage finding those enthusiastic, well-qualified team members. Don't forget about your staff. I actually kind of forgot to do this earlier, and my staff had really good, a staff manager had really good input into the workflow that we were able to later incorporate. We've also met with CGMs, so we identified a couple CGMs for our clinic that we're working with our patients, and we've met with those reps to give us some information, particularly with the technology and some tips on how we can change our settings and things like that. And then one thing that we're considering right now as we're getting implemented in the clinic is considering a patient representative to give us that patient perspective. So always think about, as far as workflow, least amount of disruption, making sure you're updating the policies, including telehealth if you're going to implement that with it, because there is some great opportunities with that. And then continuously get feedback. And it's okay, don't be afraid to change directions if need be. So now let's go over some of these CGM coverage issues. So first, selecting the right CGM, and that might play a role into the coverage as well. So we have real-time CGMs. We also have the intermittent scanning with or without alarms, and there are professional CGMs. So our real-time makes up majority of the ones now. Dexcom G6, also Dexcom G7 is just coming out, FreeStyle Libre 2 and 3, Guardian Connect Eversense. So these are just some of the examples, but really they just continuously check. So once you put the sensor on, they're checking every 2 to 5 minutes. As far as the intermittent one, this was more the FreeStyle Libre 2, where you actually have to scan to get the result. And then professional CGMs, and we're going to dive into these a little bit just really quickly. But basically, these are ones that your office provides and owns. They're clinic-based owned, so they're not ones that the patients own themselves. And there's 2 of these products, Libre 3 and then the Dexcom Pro. And so what's the difference between the professional versus personal? Again, one's owned by the clinic, one's owned by the person with diabetes. It can be blinded to the patient or unblinded so they can see the results. But for professional ones are also going to be very short term for where the patient only has like a one-time use sensor for 14 days versus the personal. This is the patient's own where they wear it continuously and they own it. Insurance does vary with these. We're going to jump into that in just a minute. And then some of these personal ones are also compatible with smart insulin pumps and smartphones, which are really nice. Here's just an example of the 2 Dexcom G6 Pro and the Libre Pro, the professional CGMs that are available. So definitely getting familiar with the products will be very helpful. So here's just an overview chart of some of the differences where the G6, Libre 2 and Libre 3 are pretty popular. Libre 3 recently came out this year, and that one doesn't have a reader or receiver, and that's going to affect our insurance issues with Medicare right now. Because Medicare requires the patients have a receiver or reader. You are going to vary as far as the sensor and how long it wears it. So that might be a patient preference, identifying that for a patient as well. One other thing I want you to be familiar with is the drug interactions. So with the Libre, Freestyle Libres, they do have an interaction with vitamin C. So a lot of patients since COVID have been taking vitamin C and cold and cough flu season coming up. So that's one thing to be mindful to educate your patients about. But they all work pretty well, good accuracy. Libre 3 is even better, and they all have alarms to alert patients with low blood sugars, which is great. So really want to think about coming up with a process of ordering, billing, documentation, again, trying to get this much streamlined before you implement the program. So Medicare and Medicaid have very specific requirements. They need to be diagnosed with diabetes, checking their sugars 4 or more times a day, treated with insulin, multiple daily injections or insulin pump. There is a way with this multiple daily injections. We're going to talk about that in a minute. But I also encourage you to create templates and doc phrases that can be embedded. And so that way it's consistent with everyone in your clinic as well. And of course, we all love cheat sheets. So as far as CGM coverage, we think about cash. So our Freestyle Libre 2s are actually going to be a preferred cash because with major pharmacies, they have a deal going on where it's patients are only going to pay $75 a month for 2 sensors. So if the cash or self-pay, that's going to be great. For commercial, you just send it to the pharmacy. For Medicaid, it's going to vary depending state by state. For Texas, for example, they prefer to send the prescription to the preferred pharmacy, but you need to have see the patient at least 6 months, testing 4 times more, injecting 3 or more times a day, and this is going to vary sometimes by certain Medicaid or Medicare insurance plans. For traditional Medicare, we do recommend going through a DME. I'm going to give you an example that we've had really good success with. But the Dexcom G6 or the Libre 2 are covered equally that we've seen. The Libre 3, again, that one doesn't have the reader, so that one's not being covered. So it's really Libre 2 or Dexcom G6 right now. And does require the documentation. One thing is through a COVID waiver right now, we've had really good success of getting this covered with just 1 injection of insulin a day. So this has been huge, and hopefully that's going to stick around for next year. Again, Medicare Advantage, we can also send it through a DME or preferred pharmacy, for Medicare Advantage, it's also going to be through a Dexcom GME. And some of those requirements are going to be a little more strict than the traditional Medicare, even with the COVID waiver. Here is the example I just wanted to show you of ordering through CGM, and this is with Parachute. It's an online platform that you can order the diabetes supplies. So they've been fantastic to work with, and we've been using advanced diabetes supply and been getting improved even with 1 injection of insulin. It gives you all the questions that are needed for Medicare to meet those requirements as well. And it ships directly to the patient's home. So it's been really nice. Here's just examples of some of the smart phrases or for our EMR that we've created. We created one for Medicaid, one for Medicare to make sure all the documentation is there. We've also created one just for our notes too about startup to include the billing codes for startup and for interpretation of data. So I just wanted to kind of give you some of those examples. So again, making sure you're setting up your training materials. In my clinic, we have like 45 physician residents and about the same of attendings. So lots of training going on right now. So we kind of broke it up into multiple sessions. So this is just an example of something you could do to help kind of with that training process if you have a lot of people in your clinic. Making sure that you have clear roles and responsibilities, on-site training support, making sure you're studying this to see how effective it is, solicit feedback from everyone on your team, improve and repeat. So next I'm going to turn it over to Caitlin, who's going to go over the configure part of the framework.
Thanks, Ashley. And so I will be moving to the next portion of the ICC framework, which is configure. And that will go over user preferences, treatment plan, and offering ongoing support. Next slide. And so under the configure part of the framework, this helps individuals get off to a strong start with their chosen technology by configuring the tools to match their care plan, preferences, and life circumstances, and helping the person with diabetes to develop a plan to integrate these tools into self-management. And to help configure settings, alarms, and alerts based on the patient with diabetes and their treatment plan to engage with the technology and provide support they need for ongoing successful technology use. Next slide. And so what some of those user preferences might look like is, does the person with diabetes want to share their data with the clinic, which is obviously super helpful for us as providers, or family members, friends, if they're children with diabetes, type 1 diabetes, they might want to share it with their coaches or the school nurse. College age people with diabetes may want to share it with their roommate or their partner. And so you can walk a patient through how to invite them, say through LibreView, or helping them download a Clarity app or the Link Up or Dexcom Follow, just as examples for the two most common CGMs that we see. And you can help assist which information is being shared. So you don't need to share everything with a friend or a partner or a parent, but you can help the person with diabetes to identify what information they want to be shared. Another thing would be the language. So for example, a Libre reader, when you're setting it up, you can only select English or Spanish, but if someone has a smartphone and they have changed their iOS to another language, the app should switch into that language's preferences. And do they want alarms to have a noise? They may not realize it's an alarm if it sounds like a text message, and they may not be alert to it. So maybe having it go on vibrate instead of a noise, or if it could be discreet where they're at work and it's not super obvious that they're getting an alert, they may be able to feel more comfortable managing a low when it's not disruptive to a meeting or part of their day. Slide. And so when there are a lot of alarms going off, this can cause alarm fatigue. So helping the user to customize the alarms. So alert fatigue can result from too frequent alarms or unnecessary alerts when things are actually okay. And so to personalize alarms to the person with diabetes, we want to assess their current finger stick readings and their A1C, what's their history of hypoglycemia, are they aware of hypoglycemia? So when they have lows, do they have symptoms or are they not realizing it? And what's best for the person with diabetes or their caregiver? And I see a lot of patients in primary care with type 2 diabetes, so often suggesting a technology holiday can be part of their treatment plan if they're overwhelmed with the alerts or if they want to take a break from an influx of data. Next slide. And another common barrier or challenge that we see with CGMs is either sensor adhesion or skin irritation. So those are the next two things I'll be reviewing. And so I've linked some studies for your reference to read, but some studies have looked at what would impact sensor adhesion, and that can be temperature, humidity. So in the pediatric population, a smaller body surface area may decrease the adhesion, or degree of physical activity or type of physical activity. And so general counseling points which should be reviewed with every person, regardless of adhesion issues, would be to avoid applying a CGM to directly to wet skin after a bath or shower, avoid placing on broken or irritated skin, and some patients may need to shave an excessively hairy patch of skin to improve adhesion. Obviously, rotating application sites. And then a big counseling point that I provide for my patients is to take care when undressing. They may not be used to wearing a sensor, the first few weeks. And there's certain items of clothing that you can just, pull your shoulder, your bra strap down, or like the tank top down, and it can snag right on the sensor if it's on the arm, or where the pant line is if the sensor's on the stomach. And so being careful about, getting undressed too quickly. Next slide. Some things to improve sensor adhesion and manage skin irritation. So you can consider alternative sensor site placements. So of course, there's approved locations. For example, the Libre's only for use on the upper arm, but there have been alternative sites studied for accuracy, such as the back, chest, stomach. And so you can consider recommending an alternative site for your person with diabetes. For sensors that tend to fall off due to excessive sweating, you may recommend applying unscented antiperspirant 10 to 15 minutes before applying the sensor to minimize the sweating. For skin irritations, it's been studied or documented that you could try something like intranasal fluticasone, so that corticosteroid applied prior to sensor placement may prevent irritation or itchiness, and then proper removal technique to minimize irritation. Next slide. And so I have a few screenshots from the various CGM product websites. So these are sensor adhesion support products that are recommended by each manufacturer. And so I've linked this, the resources as well, because they're available in PDFs. So for example, Abbott has recommended an over bandage. So something like a Sim patch or skin tack. So skin tack can make the skin tacky and serve as a barrier. So the tackiness increases sensor adhesion, but it also serves as a barrier to prevent any skin irritation. My clinic stores Tegaderm, so I often kind of give those from my clinic supply. Skin prep is another barrier method that you can use a liquid dressing to cover the skin before the sensor is placed. And so each company has similar recommendations, as well as the general counseling points of applying to clean, dry skin, being mindful when getting undressed. If you're playing sports, maybe using athletic tape or the different types of products to cover the sensor, and just being mindful when, first getting used to the sensor, walking through doorways, getting out of the car, bumping into the, furniture, stuff like that. Next slide. And same with Dexcom, they recommend similar products such as skin tack or the liquid adhesive. Next slide. And same table of products here. You can go to the next slide, where Dexcom also offers free overlay patches to customers, and they can be requested in one of 3 ways. So a patient may call the Dexcom support line, visit the website, and fill out the patch request form, or through their G6 app on their phone. And the next slide has similar recommendations for the Medtronic sensor. And the next slide, I think, is just the second page for that as well. This is more just for your information. And the last one is for Eversense, which is an implantable CGM. And so I've not managed any patients with this, since it has to be inserted by a trained professional, and no one in my clinic is trained to do this, but similar products that you can recommend for any skin irritation or skin or adhesion to the external portion of the sensor. Next slide, and next slide. All right, and so to wrap up my section for the configure, I think for a pharmacist involved in diabetes care, it's important for us to help patients with diabetes customize their alarms and assess regularly at follow-up. So as their diabetes control improves, perhaps we adjust their alarms, or if they become more sensitive to hypoglycemia, you can always move those alarms up or down, or even turn off the high alarms if they're no longer helpful. Educating patients on proper placement and removal, and recommending various products to help improve adhesion and minimize skin irritation. I have Epic at my institution, and so in my after visit summary or through my chart, I will sometimes send patients this QR code which I created, and that links directly to Amazon for a SIM patch for the, that one's for the Libre. I can share my Dexcom one as well. And then the picture on the bottom corner is from another company that has Libre sensor patches, Dexcom, as well as Omnipod and Medtronic. And so those have fun different colors and prints and designs, which may be fun for younger patients with diabetes, pediatric populations. They are a little bit more pricey when you get the fun designs. And I'm going to hand it off to Diana for the collaborate piece of the ICC framework.
Great. Well, thank you so much. And I see some questions have come through so far, but I definitely want to encourage everyone to ask a lot of questions because we will make sure we have plenty of time to have a discussion. So in my section, I'm going to talk about the collaborate, which is really about reviewing the data and interpreting it, and then coming up with an action plan through shared decision making with the person with diabetes. So on the next slide, we can see that there's actually 42 factors that affect glucose levels. And so what this means is that care is very individualized. And of course, we think of the common ones like carbohydrates are going to increase glucose levels, and for many, exercise will decrease, and insulin we expect to decrease, as well as other diabetes meds. But it's actually much more nuanced than that, in that the effects of fat and protein can increase, and for some people it's a more level effect. Caffeine, for example, will spike some people's glucose levels even without a cup of black coffee, without any carbs. And for others, it doesn't have much of an effect. And so often it really is like a big puzzle trying to figure out what are these individualized factors and how can we adjust meds, adjust lifestyle to help to reach glucose targets. So next slide, I want to talk about time in range. And this is the way that we measure glucose through CGM. And fortunately, by having so much more information, we can look at other metrics as well. So we are aiming for most people for that 70% time in range, which is 70 to 180. And that correlates very well with an A1C of under 7%. But we also have all these other metrics. So we have the time below range, which is also a goal, as well as time above range. And a little hint is that if your patient is meeting the time below range and time in range goals, usually these other metrics really fall into place. So those are the two to really focus the most attention on. But we also have the mean glucose, as well as an estimated A1C from a metric called the glucose management indicator, and then a measure of variability called the coefficient of variation. And for the purpose of interpreting, the goal is to have at least 70% of data over a 14-day time period. Now, it doesn't mean if you have less than that you can't do anything with the data. It's just that this amount is preferred in terms of really being able to assess things like time in range and GMI, because you could imagine if you're missing half of the data, it's really hard to interpret those types of metrics. Next slide. So these are our goals for different populations. And the thing to emphasize here is that most people are going to fall into that first category with that time and range target of at least 70%, with minimizing the time above 180 to under 25%. And that includes the time over 250 of less than 5%. And then similarly, that time below range, time under 70 should be under 4% total, including that less than 1% under 54. And a good way to put this in perspective is the fact that 1% of the day is around 15 minutes. For older, higher risk patients that have more comorbidities, the alternate goal is 50% or more time in range with less than 1% of hypoglycemia. And the 50% time in range correlates very well with an 8% A1C. And then the only time that we adjust that time in range of 70 to 180 is in pregnancy. And there we have stricter goals of 63 to 140. So on the next slide, we have all of our various data management tools, and this is definitely a source of confusion for people. So I would say the most common CGMs that I see pharmacists utilizing in clinics and in primary care clinics as well are Libre and Dexcom. And so each has their own corresponding platform. You've got Libre View and you've got Dexcom Clarity. And those are free accounts, and then there's free mobile apps if someone's using their smartphone to seamlessly upload the data. Now, there are several other data platforms as well, though. There are some that are considered agnostic, that they can download multiple types of CGMs. And this includes Gluco and Tidepool. There are some nuances, like Tidepool, it can download the Freestyle Libre, the original 14-day reader. There is a way to get the CSV file from a Libre 2 or 3, but it's a little more complicated. So that's something to keep in consideration. Both can easily get the Dexcom data. And then also Eversense has their own platform, and that can go in through Gluco, as well as the Guardian, the Medtronic Guardian Connect and Guardian 3. There's the own platform of CareLink, and those can both go into Gluco, it can go into Tidepool. And that one can't go into Gluco directly. So a variety of different platforms. Next slide. So just some tips that I want to share for the data sharing is that first, find out which data platform is compatible. And if you're just using 1 or 2 CGMs in your practice, then you can get those corresponding mobile apps. You want to create an account, a clinic account, and then you can invite healthcare team members. It is much easier, in my opinion, to have one account and then create additional member logins. It is not ideal to all log in with the same email or username and password, just because of security and everything. And if you have students that are rotating with you, one of the things you can do is you can add them to your account, and then this way you've got control that you can remove them when they're done with your rotation. And it's really, even though this is just glucose data, still it's making sure that we're keeping this data secure. People can't access it that aren't supposed to access it. And then in terms of inviting patients, it will vary a little bit depending on the system, but generally they all have the ability to be able to send an email invite, or another option usually is to be able to give a code to connect the data. And so if you give the code, that's an easy way, or you can send the email. But generally, if someone's using it on their smartphone, once they're connected, that data is uploading in real time. So when you think about all the possibilities, like you can be doing population health, you can be reviewing their data every week, you can be doing remote monitoring. So it's really ideal to have that. But anyone who's using a reader or a receiver, someone's going to have to plug in their data, whether it's you or the person's doing it at home and sharing it. And then the next step is we'll decide what reports you want to look at. And the ACCP report is really that one pager that has everything. Next slide. So what I wanted to highlight here is the glucose target range, because if you have an incorrect target range, it's really going to skew your time in range metrics. Fortunately, most devices now do default to 70 to 180. However, sometimes patients, they don't know that's what's supposed to be their target range. So they'll go in and they'll actually change it. So next slide. Here's an example of where it was changed. And so the top, the person changed it to 70 to 130. And this wasn't done maliciously. The person just thought, well, I probably should be 70 to 130. If you look at that, the person is 31% in target range. And this like happens all the time, like with my students. They'll be like, oh, 31% in range. And I'm like, something makes sense here. Like 31% time in range, but this person's averaging like 165, like something's just not adding up. And sure enough, it's that target range wasn't set. So at the bottom, you can see this is the same exact patient, actually. When I changed it to 70 to 180, suddenly this person's time in target range is 65%. So it really matters what those settings are. Next slide. What also matters is all the things that you check off in terms of what you want to look at with the data. And I've included 2 examples here, Dexcom Clarity and Gluco, with how many pages you get if you check every single thing. So I don't know about you, but most people don't have time to sift through 27 pages in a clinic visit, right? So that's where all of them have an option to look at the ACCP report, and that is your one pager that will have everything. A tip I have is it is good. Go ahead and click them all, see what reports come out when you have time, not in the middle of your clinic visit. And it could be that there's other options that you really like. Like, for example, with the Clarity, I like the best day, which will show me how the day that had the highest time in range. And I like to talk about that. There's in Libre View, there's a snapshot of hypoglycemia, which hones in on all the hypoglycemia events. And many times I will make the day by days bigger so that we can see more clearly certain times when things are happening. Next slide. So in terms of reviewing data, we have something called the data model, and this is 5 steps, but honestly, it's really 3 steps in that you start off by downloading the data or accessing the data. In this step, I do like to introduce to the person with diabetes what is time in range and make sure they have an understanding of the glucose targets. Too often I've seen where people wear devices and don't get really good education to start with, and they don't even know what their targets are supposed to be, and thus they can't really take action on their numbers. Then the next step, which is like the first real step, is assessing safety, looking for hypoglycemia. We always want to fix the lows first because it's a safety concern, and often people overtreat their lows, which leads to more rebound hyperglycemia and more glucose variability. Then time in range. This is where we look at the day that has the highest time in range, or maybe it's a time of the day. And we talk about it. And here we try to emphasize what is working well with the goal of replicating it. And this is different than just going straight to like the mountains of hyperglycemia or where things are not going well. And so it's kind of a less judgmental approach, even though I know we're not judging people, but people feel less judged and we focus on the positive. Then we don't ignore where there are opportunities for improvement. And here we do look at areas where there may be more hyperglycemia or variability and try to find causes and solutions. And then we take all of that together with the person with diabetes and try to come up with an action plan. And at each step, we emphasize that this is just information. It is not considered good or bad. Next slide. So in terms of how you're reviewing all of this, I realized a lot of people struggle with interpretation, and I think it's because intertwined with the interpretation is an understanding of medication management. They go hand in hand. And so I thought it'd be good to review some of the principles here. So of course, we always want to encourage healthy behaviors and access to diabetes self-management, education, and support. For those with type 2 diabetes, we generally want to optimize use of metformin, a GLP-1 receptor agonist, or now we have tirzepatide, not both together, but one or the other, and an SGLT2 inhibitor. Some people may have contraindications or did not tolerate it, but we should always be thinking about those drugs and can we use them and optimize their dosing. Once someone's on 3 to 4 non-insulin agents, that is when you really consider basal insulin. And so that would be the first next thing to add if someone's not at goal. And then if they're still not at goal and you get to around 0.5 units per kilogram per day, or they're starting to experience hypoglycemia, then you add a bolus with insulin with the largest meal or where there's the greatest spike in glucose levels. And then you would continue adding on with all the meals as needed, if needed. If it's type 1 diabetes or insulin treated type 2 diabetes, then generally we're going to be adjusting insulin in around 10 to 20% increments based on the data. We always want to address hypoglycemia. And if we see hypoglycemia, we know we've got to decrease insulin or secretagogues. I don't care what other medications they're on, but those would be the ones I would want to decrease. And then for hyperglycemia, it's all about pattern management. Next slide. So the ambulatory glucose profile, again, that's that one pager. And just to really highlight here, we've got those CGM key metrics at the top. And then in the middle part, we have the ACCP itself. And then at the bottom, we have the last 14 day-by-day reviews. Can you click forward? Because I've got a few other graphics on this slide. So we're aiming for more green, less red. And so that is that area that's in target range, that's 70 to 180, trying to minimize that time in hypoglycemia, that time under 70. Click again. Another saying, and this comes from Rich Bergenstahl, is flat, narrow in range, FNIR. And we're always looking for that hypoglycemia first. And in this example, because there is that red that appears to be occurring overnight, that to me is a big indication we need to decrease insulin, or if there was a sulfonylurea, and likely it would be the long acting because it is occurring overnight, unless someone's correcting, like taking insulin right before bedtime. And then in the day by days, that's where we're really assessing the patterns. So I'm going to close off on the next slide with an example, with a case. And here we have Karen, and she is 66 years old with type 2 diabetes, hypertension, osteoarthritis, and heart failure. She is using intermittently scanned CGM, and we can see her AGP report here. Her A1C is 7.7, her BMI is 32, and their medications are dapagliflozin 10 milligrams daily, SGLT2 inhibitor, metformin 1,000 milligrams ER twice daily, insulin glargine 60 units in the evening, and then insulin aspart 12 units 3 times a day before meals. One thing to point out here is that shaded area is going, I can see it's going below 70 around between 6 a.m. and 9 a.m. So immediately, right, I'm thinking about the hypoglycemia. Also, this is someone who's 66 years old who is on an MDI regimen, which generally those are harder ones to get to goal without having tons of hypoglycemia. So this is a case where I may be okay with an A1C goal of under 8% and a time in range target of over 50%. Next slide. So I'm going to go through the data model. And first I start off, I get that data and I explain to Karen about time in range and make sure she's got an understanding. I do find so many of my patients are familiar with A1C, but much less are familiar with goals before meals and after meals, as well as time and range targets. So the next part of this is assessing safety, assessing that hypoglycemia. And her time and range is 55%, which may be okay for her goals, but she's spending 4% of the time below 70, including 1% of the time below 54. And in the snapshot of hypoglycemia, I can actually get all of her hypo events through this time period. And it turns out that there are 9, and you can see them sprinkled out through the day, but I'm especially concerned about the ones occurring at the nighttime. Now for time and range, I do pick the day where I see that time and range is the highest. And so I pick out Sunday, August 23rd to talk with her. That line is more in that gray zone, and that 70 to 180, along with we discuss areas to improve, which I picked out Wednesday, August 26th, where it stayed really high overnight and kind of trying to figure out what's going on there. So next slide. So in terms of the discussion and the action plan and what that looks like. So for the assessing safety, I ask her about her low events, and she tells me that she's actually sometimes afraid to give herself insulin because she goes low. And as it turned out, she's really only eating like 2 meals a day, not 3 meals a day. And we saw from that tracing that a lot of meals she was going low afterwards. And so that's really helpful information to gather that she's not taking all of her doses. Time and range. So what she said is, well, she notices when she does take all her meds like she's supposed to, her numbers are more in range. So when the day she is taking insulin, it does seem like it's lower. And also she sees how exercise, physical activity seems to help her numbers stay lower. In terms of areas to improve, so you remember that one day she was really high overnight. And she says that she does miss her insulin glargine. In fact, that she forgets to take it sometimes, and taking it at bedtime is a barrier because she does fall asleep before remembering to take it. So in terms of the action plan, what we did through all of this, through shared decision making, was we decided to move her insulin glargine to morning to make it easier for her to take it. we decided to decrease her aspart. So we actually changed it to just 2 meals because she's eating 2 main meals. And then we also lowered the dose a little bit with the thought that she's going to regularly take it. We don't want her to continue going low. And my plan for the next visit would be to actually switch her from, try to get her off of the aspart and actually get her on a GLP-1 receptor agonist because she has type 2 diabetes. Next slide. So now I'm going to go ahead and summarize everything. So hopefully you can see through our discussions here that the ICC framework, identify, configure, collaborate, is a tool that can address many of the barriers to CGM use. And there's many ways that the pharmacist can help with CGM access, initiation, education, and collaboration of data to ensure optimal use and maximum benefit. And now at this time, we would love to take all of your questions.
Thank you so much to our speakers. We did have a few questions that popped up during the course of the webinar, and so I'll go through each of them. I will answer some of the questions that did come up, which is if this webinar will be recorded and the slides present. This webinar is being recorded and will be sent out to the PRNs shortly afterwards within this week. But for the other questions for our panelists, first question is, have you seen dexterity to be a reason to approve CGM, such as rheumatoid arthritis?
I have a patient that she's on basal and a weekly GLP-1, so she's not on MDI therapy, but I did get her CGM approved and she has RA. So I think it's a case-by-case basis, but my recommendation is if I think someone is going to benefit from CGM, whether it's hypoglycemia, even on orals, or dexterity, visual impairment. I've gotten it approved for someone with stroke who's had loss of their function in their like main dominant hand. So anytime I feel like it's going to benefit the patient, I will do a PA or work with my team in the clinic to get approval, peer-to-peer, medical necessity, the proper documentation. So I think it's always worth trying. But if Diana or Ashley have experiences to share.
Yeah, I will say that I did have a patient I recently got approved with, she's Medicare, 1 injection. I submitted the order through DME, through the parachute, through advanced diabetes supply, and I answered all the questions, the amount of insulin, everything she's on. And then there was a part in there where it said other information like to provide. And the patient had recently fractured her wrist. But she was already having dexterity issues, drawing up her insulin. And so I put that information in there and it was approved. So I don't know if that's why it was approved, but it was, I specifically wanted her to be on a CGM because of her dexterity issues. And so I just really kind of documented that in that where it said other section, anything else wanted to know about the patient.
And I've had similar experiences. Often you can, there's other and extenuating circumstances where you can get it approved. Not always, but sometimes.
Okay, great. Thank you very much. This next question is directed to Ashley. The Epic Smart Phrases that were shared are great. Are these available in Epic University?
That is a great question. We thank you, Dr. Sisson. We actually just created those about 2 weeks ago. So I'm guessing Epic University is more globally defined smart phrases. As far as I know, they're just within our institution, but I'll look into trying to get them on in Epic University. I don't know if Diana or Caitlin, if you guys use any smart phrases within your EMRs that are in the Epic University, if you guys want to comment on them.
I've never heard of Epic University until right now, but I'm guessing.
Yeah, I don't use Epic. I have to use Epic, but I guess I don't use Epic University.
I'm guessing it's like what you explained. It's more of like a global, like I know how to search for public smart phrases at my institution, but I'm guessing it's more of like across institutions, but I've never heard of it.
That's great. So, Dr. So I'm glad you enjoyed the smart freezes. That's something I'll look into. Thank you.
Great. The questions are continuing to pour in, which is wonderful. We'll go ahead and move on to our next one. Have any of the panelists had any experience with getting a replacement sensor from the manufacturer when there is an adhesion issue? Resident recently attempted this with Abbott and was told that they need to send back the unused sensor.
So usually it's not such an issue. Like usually they're very willing to send replacement sensors, at least definitely the first few times. Sometimes they will ask for the replacement, so it is a good idea to keep it in case they want it back. But if it was already discarded, usually if you explain to them it was discarded, I haven't had an issue. They'll still mail a replacement out.
I had a patient tell me recently that they were asked the lot number and they had thrown the box away. And so I've had that, but I have had patients get their sensors replaced. Sometimes it takes a few days. So I, always recommend they do their finger sticks when they're not using their sensor. And, with that piece of information, I just told them to save the box, until the sensor is done in case that happens again.
Okay, great. Thank you. Moving on to our next question. What is your workflow for getting patients to share their CGM data with your account, for example, LibreView? Do you make the patient download the app and set up account information before they meet with you, or do you do it at the visit?
So I can take this one. So one lesson learned that I had is, so when I'm talking to patients about the CGMs, like before they've gotten in, I think they'd be a good candidate. I actually, because not all the CGMs are compatible with their smartphones, I will actually have them download the app first before I send it to make sure. So for example, a patient I had this morning, was prescribing him the Libre 3. So I had him, I was like, oh, this is your first time using this device. Why don't you go ahead and download the Libre 3 app? So he was able to do that. I sent in the prescription to his pharmacy. And then I actually sent him an invite through the Libre View on his phone while he was there. And I was like, oh, this should go in your email. And so he pulled it up and was like, yep, got it. And then he accepted it.
The other thing that you can do during the visit, like if he downloaded the app, you can actually just go into the app, go to connected apps, connect to a practice, and then enter the practice ID, which if you're starting a LibreView account, it's going to be like a random assortment of letters and numbers, but you can edit that to say like BMC primary care, or, your institution and maybe, your clinic name. So I've done that with patients as well, as once they have the app, instead of inviting them through LibreView, is just show them the practice ID and enter it that way.
Yeah, we do the same. We really try to get them hooked up when we're doing the education and training on it, because that way they're set up and everyone's set up for success. Also for virtual visits, we have our MAs that make sure they are set up and actually paste in the ACCP report to in the encounter, so everything is ready and good to go.
And I'll say for patients who don't use smartphones, I've invited folks to share their data with LibreView, but I've had minimal successes. I work in a health safety net hospital, so a lot of my patients don't have access to a computer. Those that aren't using, if they don't have a smartphone, they might not have a computer at home. And so those are definitely visits that I tend to do is face-to-face and won't do telehealth because I won't have access to the full reports. With LibreView, you can walk a patient through like how to find the time in range and their averages, but it's not the same as the nice reports that you get. So I tend to have patients with the readers or receivers, Dexcom, come in for in-person downloads.
Yeah, so the only thing I'll add to that, Dexcom is really hard because the receiver only has the last 24 hours of information. The Libre, like Caitlin said, you can get the time and range, the lows, the averages. So I have done a number of telehealth visits that way. Yeah, you don't have the full ACCP report, but actually you could, if you're doing a video visit, which is how my visits are, you could get them to show the AGP, like put it in the screen so you can see it. So it's like, it's definitely better than not having any data.
Great, thank you very much. Our next question, what tools or software are you utilizing to import CGM data into the visit note for proper billing?
I just use the snipping tool. It's nothing fancy. I literally we snip the AGP report into the note, and we use Epic. Now, the ultimate goal is for EHR integration, and there's many working on it. LibreView and Clarity have ways this can be done, but there's a lot of players involved, data security, and so it's something we are working toward. Gluco also has that capability. I know Tidepool is working on it as well. So that's the dream. I believe we'll get there one day, and metrics will be in the flow sheet, and it'll be amazing. And maybe we'll even get rid of A1C, and it'll be time in range or GMI. But for today, we use the snipping tool. You could also scan reports in, which I've heard some places do as well.
I use the snipping tool as well. And one of the endocrinologists I work with at Boston Medical Center has said that we're working towards the Libre being integrated first through a sort of like a third-party thing called a Remedy, and that gets remote data into the EHR. So that should be coming, but the snipping tool is great. I know when I work remotely, with like IT and HIPAA, there are certain things I can't snip and screenshot on my personal computer. So I've made a smart phrase similar to what Ashley's showing on the screen, where I just put in like the GMI, the time in range, the glucose variability, and I put in those key data points so that they are there for the interpretation.
And the Clarity, Dexcom Clarity, on that first overview page, there's actually on one of the little icons, it does have like a copy to text. So I'll use that as well to kind of just put in, but it doesn't give you all the nice graphs and everything. It's just essentially like what percentage are they in each of those categories of the time and range, the data range. So that's mainly just for billing and documentation purposes. But yeah, other than that, we use the snipping and Epic Haiku.
All right, great, thank you. We are coming to a few more minutes before our webinar officially ends, so we'll try and get through as many questions as possible. Has anyone worked with a patient using a CGM who was able to get mealtime insulin removed due to improvement in blood glucose? If so, did this result in the patient losing access to the CGM?
So I've tapered, discontinued. I actually had a patient I saw today. He used to be on basal bolus at diagnosis in February, and he's now on metformin only. I think other things have probably happened. He started exercising, he's trained his diet. He still has the CGM, but those are concerns I've had myself. He's not Medicare. He's part of our Medicaid. So I would imagine that when his PA is expiring, it may not be continued unless there's a letter of medical necessity, but I can't justify that for metformin monotherapy. Other patients, I have gotten it to continue, but I think it's insurance specific.
Yeah, I've had that happen as well. One thing right now is there's still a COVID waiver with Medicare. So that means if it's a Medicare patient and they're still on a basal insulin, often through many DMEs, you can still get it continued. But yeah, I've had the whole gamut. I mean, some have had to stop their CGM or they switched to a lower cost CGM because they still really wanted to use it. So it is, unfortunately, it is an issue. Now, the good news is Medicare right now, it's up for comment that they're trying to adjust the criteria. So it would just require one insulin injection a day or being at risk of hypoglycemia. So we are seeing coverage improving, but it is a risk if someone falls out of criteria because they're doing so well with the CGM.
All right, and then I think for the webinar itself, we'll have one last question. How do you handle cost barriers with patients whose insurances cover CGMs but don't lower costs to be affordable, where the insurance coverage price is about the same as cash price?
So I think, yeah, I saw in there about how $75 is a significant amount for some patients, and that is true. So I've gotten creative. It doesn't have to be all or nothing, although data does support continued use does have the best outcomes. But for many, we can do things like, okay, if it's $75 a month for 2 sensors, for example, with Libre, maybe we do 1 sensor a month, and boom, that's taken it down. Sometimes with those good RX, sometimes you even find better deals that are lower than the $75. But even if it has to be 1 sensor every 2 months, I mean, something is better than nothing. The other thing is I love professional CGM. So that is something that is usually covered by insurance at least twice per year. And in terms of who it covers basically anyone who has a diagnosis of diabetes. They don't even have to be on medications. So that's a great way to introduce CGM and still get some of the benefits, even though it's not continued use all the time.
Okay, then. So with that, our webinar has officially come to the close for the allotted time frame, but I believe some of our panelists will be available to speak for a little bit, a few minutes after past the webinar time. Would like to say thank you to all of our audience members and of course our panelists for taking the time to share their experiences and expertise regarding CGM troubleshooting. We'll open the session a little bit, as I mentioned afterwards, if anybody has any other questions for our panelists. Otherwise, a recording will be sent out to the PRNs so that anybody who was not able to attend will be able to get this information later on.
Great. So you want to continue answering some questions now? Awesome. So one of the questions I see on here is about billing, I think, for interpretation, using the CPT code 95251 for individual pharmacist visits, or only using it during a joint visit with providers, or not using it at all. So I'll tell you what we do. So we, the pharmacists do the 95251, and they're not joint visits. We have a collaborative practice agreement, so we are adjusting medications based on that data. Now, because Medicare says that 95251 should be billed by an NP, PA, or physician, we have our notes co-signed by the ordering provider, and we do list them as the billing provider, and then we list ourselves, the pharmacist, as the service provider. And it can bring in a pretty good amount of revenue. We also have an interpretation pool where providers can send it to this pharmacist run pool, and someone will review it and offer recommendations, and it's billed. So we are doing a lot of billing with the 95251. Caitlin or Yvette, you want to, or not Yvette, Caitlin or Ashley, you want to answer?
Currently not billing for 95251, just 95249 and 95250. I brought up 95251 as an opportunity to generate revenue. I have scope of practice, and right now doing the same things as Diana, making med adjustments, putting them under the physician's name. So I don't see why that's not the next step for us, but there's just been, I don't know, maybe some compliance, and we've met with revenue reimbursement and folks to get that ball rolling.
So I work in a very team-based care clinic. And so I currently don't bill. I don't know if it's the same with other states, but essentially we can't double bill. So for example, we do a lot of like co-visits, or we do team-based visits where I'm part of the team seeing the patient. And so like I can't bill separately, or we can, if we both bill, the patient only gets billed once, and it's going to be the lower amount. So we bill under the physician, and we add the modifiers.
Great. There's a question on here about, let's see, do you think the COVID waiver with Medicare will ever go away? So the answer is, it keeps getting extended. Like there was another 3-month extension and then it keeps getting reevaluated. But if these new rules pass, then the COVID waiver really would not need to be extended because the new rules would replace it and would allow people with once a day injection to get approved. Now, the interesting thing is what happens when weekly insulin is available. Insulin icodec has been studied. Then what's going to happen? So we don't know. But the answer is that we're hopefully once a day insulin will get approved. So I see another question in here about how are you billing for 95249? What's your clinic process? So for those that don't know, 95249 is for CGM education and training, personal CGM. It can be billed once in the life of a device at the start, although you do need 72 hours of data before you can bill it. So it's a little tricky because instead of being able to bill it right when you provide the education and training and you place the sensor on a person, you actually have to wait until they come back to be able to bill it. So yes, we are billing it. I don't know that we have the best process in the world. A lot of us kind of, whoever placed it on, we schedule a follow-up or we schedule a follow-up with someone else and we alert them. And we do, like, we'll leave a sticky note for ourselves. We try to make sure it's billed at that next visit. But really, I bet if we were to audit ourselves, I'm sure many patients have fallen through the cracks. So I'm curious, Caitlin or Ashley, if you have any good process with this.
I use the sticky notes as well. So on my sticky note, I'll document the day the teaching was done and the device in case in the future they get switched from, a Libre to a Dexcom or even the Libre. I still have patients, we didn't talk about it, Libre on 14-day, really old CGM. So I'm switching them to 3 and doing the teaching for that. So I use the sticky note feature. And I follow my own patient panel. So they typically are being booked back with me. However, I do share patients with endocrine as well. So they may see the RN CDE or the PharmD CDE in endocrine before they see me. So I will flag them and alert them. But like you said, I think they definitely get lost. And I know today's talk was on barriers of CGM. I did a teaching on a Libre in April and I still have not dropped the code. Every time the patient's scheduled with me, she's admitted or forgets to bring it or only brought the glucometer but didn't bring it, is wearing the sensor but didn't bring the reader in, doesn't have a smartphone. So I think there's definitely barriers to missing that billing opportunity as well. Patient and provider specific barriers.
Yeah, we're really bad about using stickies. I would love to say I would love to incorporate that in the workflow or design process, but as a whole with our clinic, we are awful at it. So usually I kind of do the same thing. I usually will help a patient download, get them all set up, and then I usually schedule them in a week or 2, maybe even just through telehealth, and then do it that way.
I do like the remote ones as telehealth because it's easier to not lose those patients because you can just pick up the phone and quickly look at their data through LibreView or Clarity and do that charge as soon as 72 hours. But the ones with the reader, it's definitely more difficult getting them in, transportation, those types of other healthcare barriers or health system barriers.
Absolutely.
Great. And I think if I'm looking correctly, we have one more question. And that question is, well, how does laying on the CGM sensor affect the tracing? Does it tend to go high or low, or is it patient specific? So Caitlin, I'll give that one to you since you're nodding your head.
I've worn them as well just to practice, and I lay on my side of my arm. So I've had the low alerts come on my own personal CGM when I've been practicing. And that's generally the experience that my patients have is they lay on their side, they get a low alert in the middle of the night, they wake up, they scan the sensor, and then it's actually back to normal. And so I believe at least with the Abbott Libre, they've identified that it can be pressure activated to cause a low. So that's another kind of counseling point is like if they sleep on their side, maybe putting the sensor on like the inner part of their arm instead of more on the outer part, putting it on their stomach, or making sure that they have their glucometer near the bedside to check if it truly is in fact a real accurate low.
Yeah,
I've
and just
incorporated that. Oh, I'm sorry. I was going to say, I just
no, go
incorporated
ahead,
that.
go ahead.
I've incorporated that. It's just the education point with patients, and I ask them if they're a side sleeper and just kind of educate them on the compression lows. And then kind of like, making sure they're putting it on the other one or same site. And then same with the Dexcom with the abdomen. I tell them not to like put it on like where their band is going to be, like for their jeans or like their waistline or things like that.
Yeah, I completely agree. So the compression loads can happen with any CGM sensor. And also when you're reviewing the report, it's important to ask about that because, right, it could be there is more than 4% hypoglycemia, but a bunch of it was compression lows. So it's definitely very important to evaluate it. Sometimes as a sensor is dying, it will run falsely low as well. So these are all things to kind of ask about and look for in reports, especially as you're evaluating that time below range. So I think we have addressed everything. I know Yvette had to hop off, but I want to thank everyone who's still on for sticking with us. Hopefully, we hope this was helpful. I'm sure all of us will be available to answer additional questions if you have any. And this recording will be available. So yeah, hopefully you guys enjoy it. Thanks so much, everybody.
Thanks, everyone.